Hi, everyone. My name is Brittany Morrison, and I am your host for today's conversation with Texas Oncology, Wonders and Worries, Hospice Austin, and Austin Palliative Care. And I've had the experiences of collaborating with many of these organizations, and I'm very excited to be here with them today to have this very important conversation. This conversation today is a follow-up from our previous conversation on curative disease. So if you haven't yet listened to that episode, I encourage you to go back and listen to that first. Today, we revisit our patient and family from the previous conversation. A 42-year-old mom of 3 was diagnosed with metastatic breast cancer. After months of treatment, new scans showed progression. During a quiet appointment, her oncologist gently explained that her cancer was no longer curable. The language shifted. Words like curative were replaced with life-prolonging and quality of life. That shift became the moment things felt different. Treatment didn't stop. Infusions continued. Appointments still filled the calendar. But now, alongside lab works and scans, there were deeper conversations about goals, time, and what matters most. The medical team was still doing exactly what they were trained to do, guiding treatment thoughtfully, managing symptoms, and supporting her medically, but the care plan expands beyond the disease. The oncology team continued guiding treatment decisions thoughtfully and skillfully. When curing cancer is no longer the goal, families need more layers of support that prioritize comfort, build preparedness, foster honest communication, and construct memory-making, legacy-building opportunities. Today's panel discussion highlights what collaborative care can look like in Central Texas for families navigating non-curative cancer and how oncology, palliative care, hospice, and child-focused support work together to support the whole family. And now I'd like to introduce our panelists. Today, Dr. Hudson of Texas Oncology joins us to share more about clinical care during advanced cancer. Dr. Hudson?
Hi, and thank you so much for having me. I'm honored to be here. My name is Kathryn Hudson, and I am a medical oncologist in Central Austin at Texas Oncology. I am also the Central Texas Director of Breast Cancer Clinical Trials, and I'm also Texas Oncology's Director of Survivorship.
Thank you so much. And we also have Tatiana Sokolik with Wonders and Worries. Tatiana?
Hi, I'm Tatiana Sokolik, and I am the Central Texas Outreach Coordinator for Wonders and Worries. So my role is really meeting with as many referring professionals as I can, oncologists, hospice caregivers, school counselors, so that they know how to seamlessly send families our way to receive care.
Thank you so much. Joining us as well is Diana Wagner, wearing 2 hats today, representing Austin Palliative Care and Hospice Austin. Diana?
Yes, thank you also for having me. My name's Diana Wagner. I am the Director of Education and Training for Hospice Austin and Austin Palliative Care. I'm a hospice nurse by trade, and I'm responsible for making sure our staff is well equipped and educated, have all of the information that they need to adequately care for our patients on palliative or hospice care.
Wonderful. Thank you so much. So now to begin, I would like to clarify what we mean when we say non-curative cancer. Dr. Hudson, could you please explain what this means clinically and how those conversations typically unfold?
Sure. When someone is diagnosed with cancer, which is a diagnosis that every person dreads, the next question that they have for us as physicians is, can you cure this? Is this curable? Am I going to live? And of course, our hope is to cure every person with cancer. But unfortunately, that is just not the reality in some cases. And sometimes we hope to cure it and then it comes back. And so when that happens, we need to shift the conversation. And it's important that the patient and their family have an understanding that when cancer goes from curable to no longer curable, or we're trying to manage it, there's really a shift in our goals from really working on doing everything we can to cure, often that's very aggressive treatment, to really focusing on quality of life as well as length of life. And it's often a more nuanced discussion in terms of goals, in terms of quality of life and length of life that we also have in the curative setting. But of course, it becomes more important and more real in the non-curative setting.
Thank you. That's helpful. And when collaboration is working well in a non-curative cancer care plan, what does that typically look like? I will start with you, Dr. Hudson.
Sure. So when a patient transitions from curative setting to non-curative setting, or when we are really focusing on quality of life, which often includes things like pain management, other symptom management, mental health, nutrition, it really takes a team. I like to say cancer care is a team sport. So we as the oncology team include a lot of that supportive care, but we cannot do it all, nor should we do it all. There are a lot of different practitioner, providers, teams that have different expertise. And we hope that everybody comes together to support the patient and their family as best that we can. And so when that's working well, to me, it really looks like communication, which can be very hard in this day of age. Everybody is very busy. It can be hard to pick up the phone. Sometimes we don't get the messages that we want to get, So it can be tricky, but also a good sign is when we can tell that the patient and the family feels well supported. And so these are things that we talk about every time we see our patients. Things that are important are just picking up the phone, talking to the other people on the team, especially with hospice or palliative care. If I'm going to place a referral, we will often make a call and tell them about the patient. And especially when someone's in palliative care, I really like to be seeing the patient as well as the palliative care team so that we can really work together. Another important piece of this is really asking the right questions. You don't know who to incorporate on the team if you're not asking about things like, how are your kids doing? Do they need some support? Do they have a therapist or a counselor? Or how are you eating? And how is your pain? So the first step is really asking these questions so you know who to refer to and who to bring onto the team.
Okay, Diana, from the palliative care and hospice perspective, when collaboration is working really well and people are in communication, what does that look like from your perspective?
I mean, speaking as a nurse, we love a good warm handoff. We require it. It's really beneficial when we have patients who are concurrently receiving care for aggressive treatment. At Austin Palliative Care is also seeing them and working closely with the oncologist. And when it's time that the goal is no longer seeking aggressive treatment or curative care, and they come to us at Hospice Austin, that warm handoff is really easy when it's coming from that added layer of the palliative care perspective as well. They're in the home, they're seeing all of the nuances, all the family dynamics, all of the nitty-gritty information as well. So collaborating both with the oncology team, like Dr. Hudson said, sometimes it's a phone call, sometimes it's a physician to physician, especially for really complex situations, complex care. And so I would say the majority of it really needs to be communication and finding out, what the patient's goals are, how we can, be aligned and ride passenger seat for that journey. Sometimes we can help them navigate some of the information that they've been provided, sort of interpret what that means. We kind of know what the road looks like ahead of us. And so we can start preparing families for what that looks like and work closely with the oncologist on that symptom management. What have we been struggling with? What are their goals regarding how much these symptoms are tolerated, balancing out things like pain management and fatigue or side effects from medications. So that can often look like a doctor-to-doctor collaboration, communication sometimes between the nurses on the Austin Palliative Care team and the Texas Oncology team, for example, and just ongoing communication together during that process. For hospice, in the beginning, the collaboration can be pretty similar or the same. Sometimes they are coming from Austin Palliative Care. They've had palliative care services concurrently during their aggressive treatment for their illness. And so that handoff might look a little bit more intimate from palliative care to hospice. That's a great handoff as well because they've kind of started the process. They've started the education. They've started talking about what the path is going to look like going forward. And there can be ongoing communication and collaboration with the providers that they're coming from with just general updates. And like I said, what sticking points did you have? What was really important to that patient? And just those kinds of nuances.
When it seems like such a layer of support to avoid panicked decision making and surprises and more thoughtful planning. Question, Diana, when is someone eligible for hospice care and what does that provide to them? What are the misconceptions about what is offered through hospice care?
That's a very common question. From a benefit standpoint, eligibility for hospice is typically a prognosis of about 6 months or less. That does not necessarily mean that at 6 months, they're no longer eligible for hospice, because they're going to continue on that decline. So on hospice, we might have patients on for a very, very long time. That is something I'll probably speak to a little bit later, but I think unfortunately people avoid hospice until the very, very end. And that sometimes can mean that they are having those knee-jerk responses or that crisis management because they've been going along one path the entire time, and now their options are a lot more limited, and they're experiencing maybe a pain crisis or respiratory distress or things like that, and it feels all very urgent. And so if they do come on to hospice services a little bit earlier, then we have that education and that predictability, and we've described what the next steps look like. And we've worked on preparing them for what's to come. And that helps give people a little bit more agency for decision making. They think to themselves, that nurse Diana told me this was going to happen, and here we are, and this is what she told me I need to do at this point. So I think that, unfortunately, the average length of stay for hospice patients is somewhere around like 24 days, which is crazy when you can be utilizing that benefit for family as well for 6 months or longer.
And you mentioned length of stay. Where is hospice care typically provided and offered? Because stay could maybe mislead people or confuse them.
You're absolutely correct. So typically, hospice is offered in the home setting, but we also offer hospice in ALFs or assisted living facilities, independent living facilities. Hospice Austin has an inpatient unit called Christopher House for people during crisis management situations at Christopher House.
Okay, thank you so much. Tatiana, so with collaboration and we think about this holistic approach to non-curative cancer care, the role that the family plays. Would you mind walking us through Wonders and Worries and what your curriculum is and how you support families through these challenging times?
At Wonders and Worries, we provide free support for kids 2 to 18 when their family, their caregiver, and their parent has an illness. And it's really important that we connect early. We really like to connect as early in this family's journey as we can so that children have an opportunity to meet one-on-one with their child life specialist and really understand what their parent is going through. When a family connects with us, they will be connected to a certified child life specialist. And these are professionals in educating children on what's happening in the body. And they do it in such a beautiful, age-appropriate, developmentally appropriate way for children. So it's very different for a teenager than a little one. When they connect with that child life specialist, they'll meet with them for 6 sessions. We have a 6-session clinically validated curriculum, and they can do it in our office or virtually, but it starts with creating that bond and that trust between the child and the child life specialist. And it moves into education and normalization of everything their parent's going through, the illness, the treatments, the side effects. And the child life specialist will meet the child where the child is. Some really want to get into the cells, the cellular level of what's going on. And some like it a bit more broad. And the child life specialists really honor what works for the child. And then it moves into communication, both holding space for the children to communicate and also giving them the tools to continue to effectively communicate with their parents throughout this journey that they're on. And finally, it goes into coping skills, and each child will understand and learn what their personal coping skills are. It's different for everybody, and they'll create a coping kit that they can take with them to school and wherever they may go. And always be able to fall back on those skills they've learned. And of course, at the end, what do they wish for the future? But on top of all of that, we do layer on anticipatory grief support and legacy building for those families that it is appropriate for. And that, again, is really tailored to what's meaningful for the child and their developmental level. So we really prefer when families connect with us as soon as possible to mitigate the stress factors that they are up against if they don't have this space of someone to talk to and have this deep understanding of really what's going on.
Well, I just wanted to show you guys, this is my daughter's wishing tree that she did in her last session at Wonders and Worries. I've had some cardiovascular illnesses that are how I really also came to know Wonders and Worries. And anecdotally, I've also had experiences with Austin Palliative Care and Hospice Austin through other family members. But this was really special to me when my daughter brought it home. And as a parent who's navigated some illness, this was a really wonderful thing to see her complete and go through the exercise, and just how much Wonders and Worries helped lift the worry and provided a really great space for her. She would come home so happy from these sessions. So I wanted to ask you a follow-up question, Tatiana, about connecting the family early with Wonders and Worries. And as a parent who's navigated my own health challenges, and also as someone who's been a caregiver for others, I would imagine that the stress of knowing how to talk to your children and what to do, what not to do, the tools that you guys provide to caregivers would be a tremendous benefit and really take a load off of their wondering and worrying as well. Can you talk a little bit about that?
Yes, I think one of the biggest gifts we're able to give families really is that walking the parent through how to have that initial conversation with their child. I hear that is one of the just scariest conversations a parent has to have. And I think having the guidance of certified child life specialists who really understand how to talk to children of different ages about this exact thing can relieve so much stress from the parent and help them sort of set this tone for this journey they're about to begin. And I think that's just one of the biggest gifts we are able to give families, is kind of take that from them and give them the tools to have that successful conversation.
Awesome. Thank you. Dr. Hudson, as a provider, what difference does it make for you to know that a family has that hospice psychosocial support in place in the background, that holistic view of care?
Well, honestly, it's a relief for me because I know that my patient, their family are getting extra support that I cannot provide. I'm really focused on the cancer. Of course, I'm focused on the whole person and quality of life, but hospice and palliative care just look at it in a slightly different way and really delve more into the emotional support, entire family, planning ahead. Wish I had hours to talk to all of my patients, their families about all these things. Unfortunately, I don't. And so I'm just so glad that they have that outlet and extra support to help them walk their journey.
I would imagine, Dr. Hudson, it's a fine line to walk of suggesting these services to patients and families when they're inundated with so much information. Are there any tools that you've seen be helpful to kind of nudge families in the direction of seeking that extra support? And how do you navigate those conversations? Because, like, as I mentioned, I think there's information overload and a little analysis paralysis at times. You don't want to layer one more thing for them to do. How do you present it to them when you do tell them about these services?
It's tough. And I think it's really important to present it in a positive way. Unfortunately, hospice still has a strong stigma in our culture. And so some people just hear the word hospice and they freak out and shut down. Whereas the truth is that most of us are going to need hospice at some point in our life. And it's really a wonderful thing that can come in at the end of someone's life. But I will rarely start with the word hospice, and I will start with the word palliative care. I will tell them that palliative care is an extra layer of support that can focus more on aggressive symptom management, and quality of life, pain control, and often you get a whole extra team of people who are there to help you through this. Just because you're adding in palliative care, or even if you're transitioning to hospice, that doesn't mean that you're going to die very soon. It really doesn't mean anything about that. just means with whatever the natural course of your life is that we have the opportunity to bring in these specialists to help make it as comfortable as possible. But it is a nuanced conversation. It goes better some days than others. So you also have to follow the lead of the patient and their families, of course.
Yeah. And I imagine that mental health component, you know, encouraging folks to take care of their mental health and how having these layers of support with organizations like Wonders and Worries or Hospice Austin, APC can help them navigate those things too. There's other benefits, specifically with Wonders and Worries, helping people process anticipatory grief and things like that. So segueing a little bit toward that palliative hospice care, Diana, can you speak to how better managing a patient's symptoms and pain and their overall health journey, how does that allow them to create those memory moments and to more meaningfully spend time with their loved ones and children?
That's a great question. And it's usually one of the first goals or priority conversations that I have when we're first meeting our patients and family members. When we have patients who are very symptomatic because of their disease process, what they tend to struggle with is balancing palliation of those symptoms, but then dealing with the side effects of those symptoms. So maybe the medications make them really fatigued or give them anxiety or whatever it is. And so they are resistant or reluctant to start some of these palliation medications because they're afraid. They want to be as alert as possible, as long as possible, so they can be there for their family and soak up every minute. But what I often end up having to tell patients is, okay, well, let's optimize that time. Let's optimize your level of alertness at times that it's going to be most meaningful. Because, I'm not alert from 7 a.m. to 10 p.m. And I'm not dealing with chronic pain and fatigue and things like that, other symptoms that they might be experiencing due to their illness. But I think that without good symptom control, then we're talking about suffering. And suffering can be very, very consuming. So even though the patient might be physically present with their family members, they're so utterly consumed with their symptom that they're not truly present during those times. So a lot of that navigation is about optimizing the time that they have, for a family member with young children. What's the most important part of the day that you spend with your loved one when they get home from school? Okay, great. Let's do our symptom management medication timing around that time so that you are most alert and feeling most like yourself at that time. And then we will deal with the rest. I think that's why good symptom management and having somebody really spend the time to navigate what their goals are and making those our goals. And then sometimes having that hard conversation that, what are we weighing out here? You're either going to be dealing with a lot of pain or you're going to be dealing with the fatigue that comes with that. So just balancing those things and dealing with the reality of the situation and optimizing that time in those moments.
I just want to add, I think that those are such important parts, Diana. Unfortunately, when one has an incurable cancer that is leading to the end of their life, and we know that one is at the end of their life, we really want to make that time as peaceful, however the person wants it. Like it's important to stop and think, what do you want that to look like? And what I love about hospice is you really sit down and have those conversations and figure out how to make that happen. And so when I'm talking to patients about this, I tell them that my personal experience, hospice has been a really beautiful time in my relationship with my loved ones who have been on hospice. And I really think that's because hospice allowed that to happen. And it really could have gone the opposite way. And so I really cherish those memories I have because of hospice. And so sometimes talking about personal experiences can help as well, especially when it's wrapped up with something that we don't want to go through. No one wants to lose their loved one, but unfortunately it happens, and there is a way to make it as beautiful as possible.
I completely agree. I also, like many people here, have a personal experience with hospice and a loved one on hospice. And I'd say many of us, it's our first exposure to it and draws us to that. And, there I am, a nurse, very experienced and very skilled in all of these things. But it took the team saying, we're focusing on the wrong things here. And, there were moments when they were like, it's time for you to just be a daughter, not a nurse. So sometimes even those additional layers are just really, really beneficial during the hospice experience. And again, why it's so important to come on service or utilize those services earlier so that that rapport and those goals are very clear amongst the entire team.
It's a very scary time. A lot of people are very fearful, and they're not sitting there thinking, how can I strategize and optimize the medication dosing so that my loved one is maximizing their final days, these final months of their life. It's, I don't know what I'm doing, and I am just trying to make it through each day. And whether you're a child in that situation like I was as a caregiver or an adult, I do believe that having that coordinated team of support can do is provide that space for beauty to show up in darkness, and for there to be relief during heaviness, and to create those really powerful, beautiful memories with your loved one. Many people wait so long to bring hospice into the fold, sometimes even just hours and mere days before their loved one passes away, when truly they could have been benefiting from those services for 6 or more months and missing out on that support. And especially, Tatiana, I think that speaks to the involvement of Wonders and Worries with children watching their loved one in the final weeks and months of their life. That can be a bit traumatic, and understanding how do we prepare the children for seeing their loved one decline, and what are the communication tools between medical teams and parents and child life specialists that can better support and prepare these kids for what they're going to witness.
Right. One thing I love about our program too is, once a family has done those initial 6 sessions, they're able to re-access a session with their child life specialist as things kind of develop and change, which can be really helpful in cases like this. As things progress, they might need to have another check-in. We hear a lot from our families that they're so focused on their child that they're not even able to focus really on what's going on with them, that optimization and things, because they're so overwhelmed with what's best for their child and just worry for their child. And we hear from a lot of our families that once they're with Wonders and Worries, they know that child has somebody to talk to and somebody that's explaining what's happening, and they can take a step back and focus on their care and how to optimize and strategize and think about those things, because they know their child has that space and somebody caring for them, which is just such a huge gift that, we're able to provide.
Absolutely. And both to the patient themselves as a parent, but also to that caregiver. I mean, just really so much that each is holding, whether you have children or not, but especially when you have children, wanting to make the most of the time and also give the best to one another. So you guys are definitely a blessing for those families. I want to shift a little bit to talk somewhat briefly about some of the barriers to collaboration. I think part of what spurred the idea for these episodes was, gosh, people just don't know that these services are available and that they can all work in concert together. This isn't just a siloed program that this goes here and this goes here. These can be a beautiful symphony of services that prop people up during some of life's most difficult times. So, Dr. Hudson, I would love to hear from you. What are some of the barriers that you see from the oncology perspective to patients accessing this type of care outside of their medical teams?
Yeah. Well, as I mentioned before, I think the biggest thing, unfortunately, is the stigma. And so we all need to work together to really battle that and try to change that, normalize palliative care and hospice in general. So I think that's really important. And then there are other barriers as well that maybe you wouldn't think about necessarily. When I started practicing 10 years ago, we had much fewer medications than we have now. Now we have so many medications. It's often like, okay, you could just keep switching medications forever, where it's that you used to be able to say, okay, well, we don't have any more options for you. Like that just doesn't happen as much anymore because there's always a next medication. So it just takes a little bit more time for discussion and what the patient's goal of care is to really get there. Also, when one is on hospice, this is not true for palliative care, but when one transitions to hospice, they are typically saying they're going to stop life-sustaining measures. So that is chemotherapy or immunotherapy or targeted medications for cancer. And so some people are reluctant to do that, even if it's not working anymore. Another common thing I see is blood transfusions. Some people, especially with blood cancers like leukemias or lymphomas, really rely on blood transfusions to stay alive. And if we're going to stop that, it means that their time on hospice, or if they're no longer getting transfusions, is going to be really short. And so it could be really hard for someone to accept that, okay, I'm going to stop a transfusion and I'm only going to have a week left. So I think it's harder when it's really staring you in the face as something that's coming up very quickly. And then others are afraid of just the transition away from their medical team. And so I always tell my patients, just because you're going to hospice or you're doing more palliative care, like it doesn't mean we're getting a divorce. I'm still here. We can still meet. I'm still your doctor. We're going to work together, because that's a really common misperception that is a big barrier, I would say.
Dr. Hudson, I'm going to ask you to follow up just by sharing what one thing you wish families understood when cancer is no longer curable.
I think there's so much focus on the cancer, the big C. We want to do everything we can to, putting in quotations, fight against the cancer. And when cancer is no longer curable, really our outlook has to be much more broadened. It's not just about the cancer. It's really about you and your life and your family and what you want that to look like from now until whenever it is you leave this earth. And so I just wish people would think about it more holistically. And I think that is maybe a little bit tough in our culture. And, you hear so much about fighting cancer and fighting the battle and losing the battle. It's really not about any of that. It's really about what your goals are for your life and your family.
That's really insightful. Thank you. Diana, I would like for you to please talk about what you see as barriers to collaboration, and also what ideas that people have about what it means to bring hospice on. And I think sometimes the misaligned expectations around that. Are you going to have round-the-clock care because you have hospice? What are, obviously some of the things that hinder people from accessing the types of hospice care they need? For example, going to Christopher House when they really should potentially make that move instead of being served at home. Can you speak to that for me, please?
Yeah, I mean, a lot of it is we're restricted by their insurance benefit. So it's how insurance see the illness and what's covered and what's related to their terminal illness. And we refer to it as their level of care. So if they're at home, their level of care is routine home care. They would have to be eligible to go to Christopher House, which would mean an increased level of care. So that would be for somebody whose symptoms are not well managed in the home, somebody who is in crisis, that we need really rapid titration of medication and really close oversight of getting them comfortable and well palliated. And sometimes that's achievable and we end up sending them back home. But as far as, barriers to care and misunderstanding of what hospice means, some people still think that hospice means hastening death. And that's not at all what it's about. One of my favorite things to see in our patients that come on service is sometimes they stop taking a lot of these medications that are making them feel terrible. And, it's like patient-driven care. They get to do what they want, finally. That makes you feel like crap. You don't have to take it. Let me tell you what that's going to look like. I'll give you option A and option B. And then, sometimes we really see a nice boost in energy and boost in just their mental health within the first couple weeks of coming on service, because there's just this shift in goals. And sometimes, they're not having to do some of the things that are exhausting them, like making it to doctor's appointments. They're tired of going to the hospitals. They're tired of going to the hospitals and then going to rehab afterwards. They're tired of all of that. So when that goal shifts to how am I going to spend these days, as the outcome is going to be the same either way. But hospice does not hasten death. It enhances that quality of life during the time that we have left.
Thank you so much. And Tatiana, I'd love for you to speak to some of the challenges that you see for people accessing the type of child-focused care that Wonders and Worries provides.
Yeah, some of the barriers we see are people just not being aware that we're a resource, which is why I love collaborating with Hospice Austin and in Texas Oncology, because they can refer their patients directly to us and we'll reach out and connect with them. And some of the other barriers are a stigma around asking for emotional support, and that can be challenging. And then also discomfort talking about death with children. I always encourage families, if they're not sure if they want to receive our services, to call our helpline or at least have that initial conversation with a child life specialist to understand more about our program and just understand the importance of really being honest with the children and really educating them about all of the steps that they're going to, see their parent go through. So that's always my encouragement is have that conversation with the child life specialist and better understand.
My last question to everyone is, in one sentence, if you can describe what collaborative care means to you, what would you say?
To me, collaborative care means taking care of every part of that person, their physical health, their mental health, their family. That's usually the most important part of anyone's life. So being able to take care of their family and all parts of them.
Diana, what about you?
I think Tatiana really captured that for me as well. It's a holistic approach. It's all of the things, all of the nuances, all of the people that are involved in that patient and their life, and being aligned with what that patient wants and seeing us meet that goal is one of the most magical things I think I've experienced as a human being.
Dr. Hudson, same question to you. What does collaborative care mean to you?
To me, collaborative care means communication, most importantly with the patient, but also with their family, with other providers, with other practitioners, nurses, palliative care, who are helping the patient. And we cannot give a patient this collaborative support without first discussing it and asking those questions. So I think it all stems from communication.
I will just add personally, I think one of the most beautiful things about this symphony that we create by collaborating and communicating across all of our organizations is the way that not only is the care centered around the patient and the caregiver and the children, but it focuses from a non-curative perspective on those of us who are left on the other side of our loved ones passing. And I view all of these services as this warm hug that come in around a patient and their family, that embrace it doesn't just let go. I think it's a relationship that you enter into with all of these team members, and really a genuine understanding that you are cared for and your loved one is genuinely cared for. So to close, I will just, reiterate that non-curative cancer does not mean that you're giving up. It really is just a shift, and we're focused more on comfort and clarity and connection and presence, and really trying to work together so that families are not feeling alone as they navigate these journeys, and that they feel supported medically, emotionally, and relationally. So I would like to thank all of our wonderful guests, and to our listeners, thank you for being a part of this conversation that I hope makes you feel less alone. I'm so grateful for you showing up for this really important conversation that I hope really helps lots of caregivers and patients. Thank you so much.